by laparoscopic and robotic surgery for the pelvic organ prolapse and stress urinary incontinence. So I welcome ma'am.
Good afternoon, everyone. Okay. Can we have the presentation when you are ready? So while they are getting ready, we can talk about something else. So maybe we have few minutes. So while today we are going to talk about surgical management, so trainees should never think that they need to do all the surgeries or they need to learn all the surgeries. They don't know surgeries. That's why they are trainees. Okay, so nobody should feel ever bad that they don't know this thing or they are not skillful. So I'll give you an example. When I finished my MRCOG all parts, I was at that time I was working in Saudi Arabia as a junior house officer. So junior house officer means just writing histories and writing discharges, not even touching the patients. So I had no surgical exposure and I had no surgical skills, but because I had a lot of time on my hand, so when I went home, I really studied hard. So I went to the UK for a couple of courses and then I went for exams and luckily I passed MRCOG in first attempt. Now think about my situation. I have got the biggest degree and I know nothing. Like I have no surgical exposure because I didn't do any training in Pakistan. So when I went to the UK, then I came back to Saudi after passing my exam, and then from Saudi Arabia, I applied for a job. And the first job I got shortlisted was a clinical fellow in Obs and Gynae, which is like a registrar job in Wales, in North Wales. So I went for the interview, and in interview they asked few. There was the whole board in the boardroom, quite a few consultants, directors, everybody was there. So they asked me few questions, theoretical questions, few scenarios. I kept answering, and at the end I said, "Can I say something?" They said yes. I said, before you even think about giving me this job, you must know one thing. And they say, what's that? I said, I know nothing. I'm a very risky doctor to employ because I have not even done ever cesarean sections. I don't know how to do instrumental deliveries. I don't even know how to read CTG. So you might think I am MRCOG, but actually I know nothing, and that's the whole idea. I want to come here to get trained, but I don't want you to be in dark. So don't offer me this job if this is not acceptable to you, and I cannot do any on calls alone because I need someone to shadow, so who I can shadow. And they were shocked because people, when they go for interviews, they try to prove that they are the best doctor, their knowledge is best, their skills is best, their CV is best. So everybody went quiet in the room and they said, okay, thank you, and you wait outside. And then after 5 minutes, one of them came and they said, okay, we have decided to offer you the job. And they said, we will give you somebody for 3 months. You will do on calls with them and then you will shadow them. So I stayed in that department for 2 years, and everybody used to make joke of me that nobody has ever done an interview the way you did. That I know nothing, I don't know anything, I don't know cesareans, instrumental deliveries. I have never done this. I know how to take history, how to discharge a patient because I'm a junior house officer. So honesty is really important in whatever we do in life, and that is the only foundation of success. And we should never try to be someone else when we go for an interview. And the easiest thing to remember is the truth. So that always remember, when we are trying to be someone else in the interview, we will make mistakes. And easiest thing to remember is the truth. Always in life, when you are confronting someone, when you are in a court or when you go somewhere, the easiest thing to remember is the truth. So being honest is really important. Okay then, so let's start. I hope you're ready now. Okay. So the reason I told you this story because all the presentation today is about surgical skills and various surgeries which we are going to discuss. But never to get disheartened if there are some surgeries which you have never heard of or some surgeries which you don't understand. Because this is a journey. We all have to take this journey. And it is also said that even a journey of 1,000 miles starts with a single step. So this is the first step you all are taking in urogynecology, and you should have faith in yourself. And hopefully this journey will become easier and easier. And there is another quotation that well begun is half done. So if you start something with motivation and honesty, everything gets easier. So let's see what's there in this presentation. So we have been talking about various modalities so far. Conservative management, we have discussed quite a few things like weight reduction, awareness, health education, fluid management, pelvic floor exercises, pessary management, but definitive treatment of pelvic organ prolapse as well as incontinence is surgery. Okay, so the reason we emphasize so much for conservative management because surgery for prolapse and stress incontinence is not perfect. So at best, the success rate will be 70 to 80%. And if somebody is excellent, maybe 90%. And there are 10% risk of serious complication, okay? And then in total, 20-30% risk of minor to moderate complication. And some of the complications could be irreversible. That's why it's really important to know that it is not perfect. So sometimes we are better off with conservative management. So the problem with the prolapse is that no two patients are same. So one woman can have prolapse in one compartment but may not be symptomatic in that compartment. For example, somebody has a cystocele and she has not much symptoms of cystocele, but actually she has presented to you with stress incontinence. But when you have examined, you have found a cystocele. So she has prolapse, but she is not symptomatic. So that is also a dilemma, what to treat. Whether we treat stress incontinence or do we treat cystocele first. And also, sometimes there are multiple problems. In addition to stress incontinence, there is a rectocele, uterine descent, cervical prolapse, very elongated cervix. So first of all, we need to discuss with the woman what is bothering her most and then explain everything, the examination findings, and then decide. And also when we examine the patient on the couch, the degree of prolapse is less. When they are on the table, because of general anesthetic, all ligaments, tendons, and muscles are relaxed. So usually what we find is a lot bigger prolapse than what we expected in outpatient. So how do we choose which surgery? So first of all, what are the things which are affecting her quality of life? Extent of the prolapse, whether she has completed her family, are we going to conserve her fertility like uterine sparing surgery, or are we going to consider hysterectomy first? Is she sexually active or not? That's the most important point because some of the surgeries like colpoclysis we cannot do if somebody is sexually active. Age of the patient, for example, if very young patient, we need to keep the vagina functional. Fitness for surgery, if somebody has cardiac disease, can she go through surgery, or whether is there any surgery we can do under local anesthetic. Associated incontinence symptoms, women's goals and expectation. Last week, just before I came here, my last theater list, I was so humiliated because one of our own nursing manager, she was there on my list. And I saw her 1 year ago because in UK it doesn't happen that if you are a member of staff or if you have someone knows you, you will jump the loop. It will not happen. Everybody has to wait the same time. So on the day of surgery, I said, you are coming for a prolapse repair. She said, yes. And I looked at the notes and it was just posterior repair. I have documented she's coming for a posterior repair. I did her posterior repair. And what happened after surgery, that I got a call from recovery that this patient would like to see me urgently. And I went there and she said, oh, I'm so shocked. You have done my surgery, but I'm still leaking. And I said, what? I did not do any surgery for you to stop leaking. She said, no, that's what I was expecting, that my prolapse will go and my leaking will get better. I said, posterior repair doesn't do that. She said, no, but this is what I wanted and I'm still leaking and I wasted such a long wait. And you know, over there people are very upfront. they are very confrontational if their expectations are not. And I felt so humiliated that after spending 11 years in urogynecology, I could not meet her expectations. She was expecting that after her prolapse surgery, her incontinence got better. And maybe I did not clarify this to her. I should have been a bit more clear. There was some breakage of communication, but I really felt humiliated, and I apologized to her. Usually I see patients 3 months for routine follow-up, and I told her I'm going to see you in 6 weeks' time. We'll talk about it and we will see what we can do. But I'm telling you, you may consider me as an experienced urogynecologist, but even in my daily practice, sometimes people can be shocked that their expectations are not met. So women's goals and expectations, that point is really important. Work, physical activity, domestic circumstances, previous management and outcome, and surgical experience and familiarity with different surgical procedures. The last point is really important for the surgeon. Do the procedures you are familiar with. Don't do the procedure which you are completely new or you have never seen, because you will be in trouble, because troubleshooting is really bad in urogynecology. General rule. So we give antibiotic cover, but only one antibiotic shot we give during surgery. We don't give 5 days of antibiotics or 3 days. It is just one antibiotic when we are inducing for general anesthetic or spinal anesthetic. Thromboprophylaxis is the most common one because DVT is a common problem after any pelvic floor surgery. So this is the top of the list. Everybody has Clexane for thromboprophylaxis, and everybody has TED stocking. Do we have TED stocking here? Like special stockings to prevent thromboembolism? Do we have here or? Okay. So they are 100% must there. Even for day case surgery, they have TED stocking, and major surgery, they have to put on those stockings for 6 weeks and 7 days of Clexane. And if they have a risk factor, for example, antiphospholipid syndrome or any other problem, then they have 28 days of Clexane. So we have to discuss route of the surgery, which is vaginal, abdominal, or laparoscopic. Anesthesia we have to discuss. The good news is that a lot of surgeries nowadays I do under local anesthetic, and a lot of things we have moved to outpatient setting, which is really great. Since we started doing colpoclysis under local anesthetic, that has transformed the service for women. And a lot of surgeries are day case surgery. I don't know whether you do vaginal hysterectomies at day case? No. So all of my vaginal hysterectomies we do as day cases. So unless the patient is last on the list, because my list timing is 8 a.m. till 5 p.m. So if I have done her after 3 p.m., then I keep her overnight. But if I have done her before lunchtime, they go home. Everybody goes home same day for all the surgeries. All urogyne surgeries apart from sacrocolpopexy and autologous facial sling. So all surgeries are day cases. Fitness for anesthesia, as we discussed earlier. Bladder care. Because our surgeries are day cases, most of the cases we do not put any catheter. And this also has transformed because it has reduced the risk of urinary tract infection a lot. So after vaginal hysterectomies, we don't put any catheter. We just do in and out catheter at the beginning of surgery, and that's all. Sorry? So no catheter at all, no vaginal packing for any anterior repair, posterior repair, perineoplasty, vaginal hysterectomy. So no catheter, no pack, and these are all day cases. Sorry? Yeah. Yeah, but if you think about it, vagina is not a sterile place. It can't be clean. Yeah, so that's I think some things we can learn from each other. Yeah, but all of these surgeries can be done at day cases, which will be so beneficial because we have no beds in hospital to keep the patients in. So all of our laparoscopic abdominal hysterectomies are day cases as well. So all laparoscopic hysterectomies are day cases. So if there is a bladder injury, which then they require catheter for 2 weeks roughly. If patient is unable to void, then or there is a post-void residual after vaginal hysterectomy, then we put a catheter before they go home. Still they go home with a catheter and they come after 3 days, or we teach them self-catheterization. So self-catheterization is used a lot in the UK, a lot. For all the voiding dysfunction patients, we have a specialist nurse. Her job is just to teach self-catheterization and provide patient a little mirror, and there is a little kit and all the disposable catheters. So if there is bladder injury, it needs a cystogram prior to trial without catheter to ensure healing. So post-operative advice is to avoid heavy lifting, strenuous exercise, prolonged straining. For 3 months, avoid sexual intercourse for 6 to 8 weeks after surgery, and avoid smoking and manage diabetes, healthy diet. And everybody who has urogyne surgery, without fail, everybody has, we provide them 6 weeks of laxatives. So laxative of choice for all patient. Every single patient goes home on docustrate sodium. So just one tablet a day. We tell them your stool must be really loose. We don't want any constipation. Any straining, any stitch breaks, then it's a risk of recurrence. So 100% everybody has 6 weeks of docusate. Okay, so this is an important document. It is available online. This is called Surgery for Uterine Prolapse Patient Decision Aid. So all the trainees should make a note of this because this is like nearly 20 pages. So it is for patients to choose that what surgery would they like. There are mention of all types of surgeries, which I'm going to mention anyway. But in this document, it is very, very easy. Lay terminology is used. So we use these two documents, surgery for prolapse and surgery for stress incontinence. These nice, and we provide patient in outpatient with this document. We give them all the option, and then we have a phone consultation in 2 weeks' time to see which surgery they would like to choose. So again and again, the NICE says that different treatment options must be discussed with the patient. So different treatment options must be discussed with the patient. We should never assume, oh, we think this is a good option for her. We should never assume. Because you are very lucky here in India because there is no litigation. Over there, if there is a litigation, everything from the very start, judges will have a look that when the patient came, what options were discussed, whether she was offered conservative management or not, is it documented that she was offered and she declined? Yeah, so it's really important that all options are given and it is documented why we have chosen the option, what we have chosen. And benefits and risk of each surgical procedure, including changes in urinary bowel and sexual function, must be documented. The risk of recurrence, uncertainties about long-term adverse effect, particularly those involving mesh. So in the UK, if you use mesh for any procedure, the only procedure which is allowed at the moment is abdominal sacrocolpopexy. The patient must have yearly follow-up lifelong of the patient. Can you believe that? Till that patient is alive, every year we have to give her one follow-up appointment every year. It is such a huge workload. So everybody is reluctant nowadays to use mesh because then it is the patient is attached to you lifelong. And there is no other mesh which is being used in any gynae practice in the whole UK or at least England, because in Scotland and Ireland some people have restarted using TVT, which involves a mesh, but in the UK it is illegal. If anybody puts any mesh in the vagina in the form of TVT or anything else, it is a crime and you will go to jail. So it is that extent. So at the moment, nobody is allowed to use any mesh in the vagina. So sacrocolpopexy mesh, you have to get special approval, only then you can use it. Okay, so we are talking about pre-op factors.
Dr. Asha, what is the reason for lifelong follow-up? Is it because of the erosion by the
Yeah.
mesh or the surrounding area?
10% of the patient where we have used sacrocolpopexy mesh, they can have mesh exposure. In the past, we used to use the term erosion. Now the term is mesh exposure. And obviously, the people who are sexually active, if they have mesh exposure on top of the vagina, they can have dyspareunia to both of them, both partners, and it can cause excessive discharge and bleeding. So because
We've
of
done
those,
a sacrohysteropexy.
yeah.
In that case, also lifelong follow-up is essential. Uterus is there. We have not exposed the
No.
mesh anywhere. It was just the
Yeah.
um, uterus between the
Inner mesh, yeah.
urocervical and sacrum, and everything is now retroperitoneal and fibroblast and fibrosis that takes place. So the risk is very less. But do
Exactly.
those cases also need lifelong follow-up?
In UK, any sacrohysteropexy or sacrocolpopexy lifelong follow-up, but everybody knows that after sacrohysteropexy, which is becoming rarer and rarer, people not doing it as much.
Nulliparous prolapse.
Yeah, nulliparous prolapse.
Yeah.
And yes, they need to be registered with MHRA.
In our country,
Yeah.
cancers, but for nulliparous prolapse, uh, we are doing it.
Mm-hmm.
At least I am
Yeah.
doing it. I've done it recently in 2 cases, but I never ask them to have a lifelong follow-up. That's why I will inform them.
Yeah, yeah, yeah.
I'm in contact with them, and I will, if that is required, I
Yeah.
do it.
So while we are still getting electricity back, we will continue talking about pre-op assessment and anesthesia and various things which we can do to help our patients where there is serious comorbidity involved in decision for major surgery. So let's talk about something which is the commonest operation which I do, which is actually the very last slide of the presentation. But we can do that first because by the time electricity will come and we will reach to that slide, maybe we all will be very tired. So the operation I'm talking about is colpoclysis. Is it a common practice to do colpoclysis here? No. So, well, I can tell you if you have a patient who is above 70 years of age and who is not sexually active and she has prosidentia, I feel personally doing a vaginal hysterectomy in that patient is killing an ant with a cannon. That is such a major surgery for that patient. If she is not sexually active, you should never do vaginal hysterectomy for a woman over age 70. The reason is because once you do vaginal hysterectomy, because there is apical weakness, there is significant risk of vault prolapse after that, and also significant risk of urinary incontinence. So all of my patients who are not sexually active and usually above age of 70, I offer them colpoclysis. And colpoclysis is, if you read in the book, it's a very complex procedure the way it is documented. And that's why it is not practiced worldwide. But since I became a Urogyne consultant, I simplified the technique. And this is the commonest surgery which I do. So, for example, in last few years, I have done more than 200. So everybody knows that this is my favorite operation, and it is either for vault prolapse, it is equally good, or if it is for prosidentia. Even minor degree, because the way I have tweaked my technique, even asymmetrical prolapse, I do colpoclysis. And the best news is I do it under local anesthetic and as a day case. So what happens then? Patient has it done, and she goes home. And my oldest patient is 97 years old who had prosidentia, and for last so many years she was using pessaries because nobody will touch her because she had cardiac disease and she was not fit for anesthesia. So it took me 40 minutes to do colpoclysis under local anesthetic. So all of you, if you need to learn one thing from today's lecture, never underestimate colpoclysis and never do vaginal hysterectomy for women who are not sexually active. Consider colpoclysis.
one question, excuse me. In colpoclysis, do you not have a problem in later on developing any malignant lesion in the cervix? Number one, and number two, the stress incontinence.
Yeah. So these are very valid
There
questions.
is traction on the anterior wall of the vagina.
Yeah.
So these two things are worrying me.
Exactly. These are very good questions. So, what it is, there is, if you look at the incidence of cervical cancer and endometrial cancer, and if you look at the peak ages, they are before 70. So a woman who hasn't developed cervical cancer and endometrial cancer before 70, it is extremely unlikely she will have cancer again. So that is one point. So all the cases I did, or nearly 200 cases, it was presented in a conference in Singapore, and I think my trainee got the award for that. Only one patient out of all those 200 patients had postmenopausal bleeding. So we had, obviously she can't have transvaginal scan. So we did abdominal scan, and still endometrial thickness was less than 4 millimeter. So she did not need any intervention. So if after colpoclysis, if they need hysterectomy, they have abdominal hysterectomy if they need. So after transvaginal scan, we do MRI if there is any suspicion of thickened endometrium, which is more than 4. And if MRI is normal, then nothing needs to be done. And stress incontinence, so when you are doing colpoclysis, you need to leave at least 3 centimeter area under urethra where your triangle is closing. If you leave less than 3 centimeter, then you have stress incontinence because then urethra doesn't close properly. There is a traction. So you must leave 3 centimeter under urethra. So your front triangle should be starting a bit low. Yeah. Okay. So what I will do, I will draw a picture in the end to show my simplified technique of colpoclysis. So maybe that will help a lot of patients. Okay, so we are talking about various factors. Now we are talking about incontinence. Whenever we do prolapse surgery, as madam has correctly mentioned, people have risk of incontinence. They didn't have incontinence before, so they have swapped one problem, which is prolapse, with incontinence. And it's terrible, isn't it? They would say at the end, it was better for us to have prolapse than to have incontinence. Why did you do this to me? So you must tell them that this surgery is associated with risk of incontinence, any prolapse surgery. But you need to make your mind clearly, is it worthwhile having the risk of having incontinence? And you also tell them, if prolapse is very bothersome, yes, we can agree to do surgery. And if you develop incontinence, you will need later investigation in the form of urodynamics. And then we can offer you surgery for overactive bladder or stress incontinence. So you give them hope as well that if you develop incontinence, we can do something about it. So that's another thing. Sometimes there is some consultants do concurrent surgery for stress incontinence and prolapse in women who have anterior or apical prolapse and have stress incontinence at the same time. The example of this will be somebody has a cystocele and somebody has stress incontinence. So they have had urodynamics, which has confirmed stress incontinence. So some consultants do anterior repair, and at the end of the anterior repair, in the past, they will put a TVT, or now they will put a sling operation. Yeah? I do not do that. The reason is because all of us who do urogyne surgery know whenever somebody has cystocele and have incontinence, there is 50% chance that just doing a cystocele repair will improve her incontinence. 50% chance, which is very significant. So I always do single surgery. I never do concurrent surgery. Because if patient is lucky, but you must tell them that you have got good 50% chance your incontinence will get better. If it didn't, don't worry. I'll see you in 3 months. We can investigate you and we can offer you surgery for stress incontinence or overactive bladder. But as Dr. Seema was mentioning, Kelly plication and all that at the time of anterior repair. So if you... yeah. So I heard that is a common practice in India. Okay, if woman's chosen procedure is not available from the consulting surgeon, refer her to an alternate surgeon. This is something of ethical value. For example, in UK, in order to have super specialization in certain procedures, procedures are divided in between colleagues. For example, in our organization, I'm the only consultant who does autologous facial sling. So if any of other urogyne consultants patients has chosen a sling operation, after she is given all the option, that patient will come to me. And I don't do Birch colposuspension. Just my personal reason, I just don't like the idea of that operation. But when I give my patient the document of surgery for stress incontinence, decision aid, and she has chosen Birch colposuspension, I send her to my colleague who does it. So it is just ethical practice. So at the end of the day, patient is happy that what she has chosen, she has been provided with. So it is about concurrent surgery, combined procedures, and must thing is a follow-up after surgery. I don't know in India whether it's a regular practice to have a regular follow-up, but in the UK you must have 3 months follow-up because you have to enter this data on British Society of Urogynecology website. Okay, so let's go to traditional anterior repair type of procedure. Nothing special in this slide, and we will see a video in a minute, and that is a nice for junior trainees to have a look. So rather than looking at this description in words, we'll have a look at a little nice video. Okay, so let's have a look. Let's play that little video at the end. So I think it is the one which I'm thinking, if it is on a mannequin. The one on the link is there, yeah. Sorry, it is the link at the bottom of the slide, this one. I hope it is the same one what I'm thinking.